Hello everyone, welcome to another Think Like a Medical Registrar series video targeted at MRCP PACES candidates. My name is Vishal Kumar, I'm the founder of this channel. Today we are going to be talking about Fred's fevers, so we're going to go through a scenario which will be based around like a PACES case but on real life, and you will learn plenty of material that is relevant for real life and for your MRCP PACES, okay? So let's get started. In this video, we're going to go through the scenario first, and then I'm going to ask you to tell me your plan, doctor. Okay? As the medical registrar, you are going to tell me your plan. After that, we'll go through some key considerations of this particular case, and then we're going to do the scenario review. Okay, and finally at the end what I'm going to do is give you a bite-sized bundle for PACES itself, which you can of course apply to real life as well. So make sure you stay with me until the very end of this video because there's a lot for you to learn here. And I'm introducing something new here in this video. If you see this icon, the bell, then pause the video and actually think about what I'm saying, okay? And think about what I'm asking you to do. This may be coming up with a plan, management, differentials, whatever it may be, okay? So pause the videos every time you see this bell. All right, let's get started. So this is Fred, who is a 23-year-old man. He's been brought in by his wife because of fevers over the last 5 days. He has been abroad to Spain for a 6-day trip 2 weeks ago with his friends. Okay, so he is fit and well otherwise and takes no regular medications. He does smoke 20 to 40 cigarettes a day and drinks socially. Okay, so a few things here. So he is a young man, been to Spain on a trip with his friends, and he smoked quite heavily. Otherwise, he's fit and well. He's feeling drowsy now, and his wife doesn't know much more about his medical history currently. Okay, so he's feeling a bit drowsy. So we don't know what's going on here, whether, he's having encephalitis, meningitis, etc. Anyway, let's have a look. The A&E team have done some vital observations and commenced treatment. Here are the observations. Temperature is 38.6. Okay, so he's pyrexic. Heart rate of 136 and it's regular. Blood pressure is 87/46. He's hypotensive and he's tachypneic at 30 a minute. SATs are 95 on air, so he's not hypoxic. All right. So he's quite an unwell man. So he's basically septic, isn't he? So this is the treatment that A&E have started on. Sepsis 6 has been started, rightly so. I think that is very much the right thing to do here, okay? And they have taken blood cultures, again, perfect thing to do. And they've given some intravenous antibiotics. Okay, so all good, I think. So we're along the right tracks here. And of course, they've done a venous blood gas, very helpful, which shows this. So pH is 7.28, so there's acidosis going on here. PO2 is 7.6 and PCO2 is 5.6. Bear in mind this is a venous gas, so don't get too alarmed with these values just yet, okay? And bicarb is 15, so it looks like this is metabolic acidosis, and rightly so. There is a raised lactate of 3.6. So indeed this is metabolic acidosis, isn't it? And glucose is slightly raised, so his drowsiness is definitely not because of hypoglycemia then. All right. So let's see what happens then. So sepsis 6 has been started and he's been given intravenous antibiotics. Chest X-ray showed no consolidation. And now, what do you think are the differentials? Here's the bell. Pause the video, have a think about the differentials and come back. Okay, so here are the differentials. So he is septic now, isn't he? So in terms of sepsis, sepsis can be from many different sources. So we need to think about the different sources of the sepsis. So commonly, these would be bacterial causes of sepsis, where it would be chest or urine as the most common cause, right? So this is the most common cause of sepsis. It could be meningitis or encephalitis. He was drowsy, wasn't he? So that's a definite possibility here. We don't know much else. So he's been on a trip. So maybe he stayed in hotels where there might have been, all kinds of bacteria. Who knows? He might have an atypical pneumonia that might be causing him to be drowsy, etc. Okay, so another cause for a septic patient can be viral causes. Of course, it can be HIV seroconversion because he is a young man. Yeah, we know he drinks and smokes. We don't really have much more information at this stage, so we have to keep a broad differentials and think about HIV, okay? So HIV is something worth considering for every single patient, especially younger ones, because of the wide prevalence of it generally in the population, and also because it is so treatable now. People with HIV can live normal lifespans, okay? So HIV is an important diagnosis to make and not miss. EBV is another possibility, okay? So Epstein-Barr virus, infectious mononucleosis may well present this way, especially if they've got deranged liver function test. Hepatitis is possible, but we don't really know much else yet, okay? It is less likely, I would say, in this case. And tropical illnesses like malaria, typhoid, I have put them in the differentials, but again, very unlikely in this case. Because he's just been to Spain, it's not like he's been to India or sub-Saharan Africa, so these are much less likely here. Anyway, so these are the differentials. We'll come back to them later on. 6 hours later, after arriving and having had treatment, he's now more alert. Okay, and there are no signs of meningism. So that's promising, isn't it? So there is no meningism and he's alert. So that pretty much tells you that this is not meningitis, encephalitis, and the CT head is clear. So fine. So that's satisfactory, I would say. And he doesn't drop his consciousness from this point onwards. So I don't think that meningitis, encephalitis would be the right route here. Okay, so that narrows our differentials a little bit. 3 days later, so a few days have passed now since he came in. He's still spiking temperatures. His inflammatory markers are still raised and his renal function is deranged. Now, this is a bit concerning, isn't it? So, despite treatment, 72 hours later, he's not responded. So, this is not very promising. So, we need to reassess things, especially because, despite treatment, he hasn't showed improvement. So the viral screen is negative. Okay, so that was sent on admission. So HIV, hepatitis, EBV, they're all negative. And the X-ray was negative, as we discussed earlier. And the blood culture has come back as showing no growth. Okay. This is a little difficult then, isn't it? So, but look, the nurses have finally managed to get a urine dip. This, as you may be aware, can be quite difficult to obtain. Urine dips can be quite difficult to obtain for logistical reasons in hospitals. Anyway, we have managed to get some, and it shows hematuria, right? So this changes things slightly, doesn't it? So hematuria in a young man who is spiking temperatures, who's been on a trip recently. Okay, so we may be thinking of pyelonephritis then, wouldn't we? So I think that would be quite reasonable to think that in this case. Do you think that there could be other causes of the hematuria in this septic patient? Have a think and come back to this video. The answer to that question would actually be yes, because we're going to go through that now, okay? So you reassess him, and he admits to having injected drugs and also acquired a tattoo on his right arm whilst he was on a holiday. He cannot be sure about the origin of the needle, though. So this changes things again, doesn't it? So this could well be HIV, this could well be hepatitis, this could be something else as well. So what could it be? On re-examination, you find that you hear a diastolic murmur. Okay. And you find tender fingertips and feel splenic enlargement as well. You see where we are going now? So what are your thoughts now? just a quick thing. Tell me your thoughts. Okay, here it is. It's endocarditis. So we'll go through his symptoms, all the symptoms in a second, but this is a case of endocarditis. Okay, so how did we come to this? So Duke's criteria is something we need to know about, okay? You don't necessarily have to know it at the top of your head, every single thing, but you need to be aware of Duke's criteria in diagnosing infective endocarditis of bacterial origin, okay? So you basically need any one major and 3 minor or 5 minor criteria, okay? So these are the 2 major criteria and these are the minor criteria. So you need either 2 of these to be positive, or 1 of these and 3 of these, or 5 of these, okay? So that's how it works. So do pause this and have a read or memorize if you would like to. But basically, in the major criteria, you need positive blood cultures, which are typical infective endocarditis organisms, okay? These are the HASEC organisms. You can Google them. This includes Haemophilus, for example, and Kingella, for example, okay? And also echocardiogram findings with oscillating intracardiac mask on the valve. Basically means typical findings on the echo, okay? So these are the typical findings you would expect in the blood culture and echo in the major criteria. In the minor criteria, you have predisposing heart conditions. These would be things like prosthetic valves, for example, or a recent cardiac surgery, okay? Or intravenous drug use, which our friend Fred here does have, okay? So he is an intravenous drug user. Temperatures of 38 degrees, which also our friend has. Vascular phenomena, arterial emboli, Janeway lesions and conjunctival hemorrhages. Or immunological phenomena like Osler's nodes, rot spots, and rheumatoid factors. Osler's nodes are what Fred has as well, the tender fingertips. Positive blood cultures which are not typical and not meeting the major criteria. So basically, organisms that are not typical for endocarditis and don't meet major criteria, okay? An echocardiogram consistent but not meeting major criteria again. Okay, so that's quite a lot to take in, isn't it? But as the medical registrar, as the registrar on your ward, what do you need to do? This is what you need to do, okay? Let's get back to Fred. You need to essentially think about patients like this and have a very broad differential. You need to assess them and look out for certain specific things that might point you towards infective endocarditis, okay? And in this case, in Fred's case, these were the hallmarks. Fevers, IV drug use, okay? Of course, this information surfaced later down the line when you probed further. Ideally, if it had come up earlier on in the admission, things would have been much more, simple from the start. Hematuria, because glomerulonephritis can happen in infective endocarditis, okay? Which is why you should ask for a urine dipstick if you're suspecting infective endocarditis, because you can look for evidence of hematuria on the urine dipstick. Okay, and splenomegaly can happen. This is usually not massive, it's usually mild splenomegaly in infective endocarditis. And tender fingertips suggest Osler's nodes. Okay, you can examine them and look for these. Splinter hemorrhages are very popular for infective endocarditis, but Fred didn't have them, right? He had Osler's nodes instead. These are all hallmarks of infective endocarditis, which Fred had, all right? So in terms of the management, it's not actually that difficult as a management. It's fairly simple. It's like any other infection, but you just need to be more careful because you need to follow local protocols and involve relevant specialties. Okay, so this is what you need to say, what you need to do. You need to obtain 3 blood cultures at least, okay, from different sites, separated by physical distance, so different sites, and also time, okay, so over a number of hours. followed by a transthoracic echocardiogram. This you can request yourself. You can look for evidence of any vegetations on the valves on the echo. But if you think that this is not conclusive, then you should definitely think about a transesophageal echocardiogram, because they are much more sensitive to picking up vegetations. But of course, these are only done by specifically trained cardiologists. So this is what you need to do in terms of involving specialties. The key things are to involve the microbiology team in advising you on the antimicrobial treatment, and also involving the cardiology team, because they will then be able to go ahead and assess whether or not a transesophageal echo is required. Okay, you are not going to do that, so you're not going to be bothering about it. What you will say is that you will involve cardiology to assess need for transesophageal echo. Okay. And we have come to the end of our presentation, probably the best bit, so well done for sticking with me up until here. Here's the bite-sized bundle that I promised for you, which you will find very helpful for PACES. The way we will go through this is in order that you would actually examine and approach the case, okay? Approach the patient. So we'll start off with the history. So in the history, you ask for things like intravenous drug use, any predisposing conditions like prostatic valves, recent cardiac surgeries, and dental infections or procedures, okay? This is the bundle for history. In the examination, the first thing you always start off with is the hands. So that's where we are starting. In the hands, you look for evidence of splinter hemorrhages, osseous nodes, which are painful, and Janeway lesions, which are not painful, okay? Followed by the eyes. You move up from the hands towards the eyes. In the eyes, you can look for evidence of rot spots, which are in the retina. You can also look for evidence of conjunctival hemorrhages as well, okay? You then move down towards the chest when you're examining a patient. So in the chest, you look for a new murmur, okay? The key thing is new, because patients with prostatic valves may well have flow murmurs, for example, and that can be difficult to tell. If you are in doubt, then you should always investigate for infective endocarditis, all right? Moving down to the abdomen, we have splenomegaly, of course, which we discussed earlier. You can get mild splenomegaly. Further down, we are now going on to investigations, bedside investigations. The first bedside investigation that you can do is ECG. On the ECG, we didn't have this in this case, but you can look for evidence of increased PR interval, okay? Because that would suggest an aortic root abscess secondary to bacterial endocarditis. Okay, followed by urine dip, which we discussed as earlier, can show hematuria secondary to glomerulonephritis in infective endocarditis, all right? Lastly, definitely not the least, that you will definitely be requesting are blood cultures, where you will look for evidence of Hayseck group of organisms or others like Streptococcus viridans being the typical one for dental sources of infections. And also, of course, you will request an echo, which we have mentioned previously. I hope that you found this useful, guys. I really hope that this was useful. If you find it useful, then make sure you check out my book, available in the paperback form and also the Kindle formats. It covers strategies for high achievers for PACES and also my course. I will see you in the next video.